Good afternoon, everyone, and welcome to our webinar, Mind Over Trauma, Novel Treatments for PTSD Recovery. My name is Hannah Sung, and I'm a journalist and co-founder of Media Girlfriends. We're a production company that prioritizes inclusion in media, and I'll be your host for today's presentation. On behalf of the Homewood Research Institute, thank you for making the time to be with us. So before we begin, note that closed captions and live transcription have been enabled for this event. You can turn these on by using the closed caption or CC button on your Zoom display, and a recording of the event will be made available. I'd like to begin by letting you know that the offices of the Homewood Research Institute are located on the traditional lands of the Anishinaabe, Arawandran, Haudenosaunee, and Métis peoples, and the treaty lands of the Mississaugas of the Credit. And I am located in Toronto, which is covered by Treaty 13 and the Williams Treaties, and I encourage you to know and learn more deeply about the relationship you have with the land you are in. HRI supports the Truth and Reconciliation Commission of Canada's calls to action and is continually working to be more inclusive in their research and everyday practices. So today we are presenting findings from a recent study on the benefits of goal management training, or GMT, and neurofeedback in reducing the symptoms of post-traumatic stress disorder and improving brain function in people who live with PTSD. We'll also learn about how PTSD impacts the brain and the gaps in currently available treatment for PTSD. This work is a partnership between researchers at McMaster University and Homewood Research Institute, or HRI, which is a national charity dedicated to research that transforms mental health and substance use treatment in Canada. So the format for today will begin with presentations by Dr. Andrew Nicholson, HRI Collaborating Scientist and Director of Clinical Research and at the Atlas Institute for Veterans and Families, James Mirabelli, who is a PhD student at McMaster University, and Mina Pichtakova, Clinical Research Coordinator at McMaster University. These presentations will be approximately 20 minutes, so you can get comfortable. Immediately following will be your opportunity to ask questions in a live moderated conversation with our panel. We would love to hear from you today. So if you have questions, please use the Q&A button at the bottom of your screen. You may share questions at any time during the presentation, and we'll get through as many as possible before we wrap up at the hour at 1 p.m. Eastern Time. And finally, before we begin, I'd like to extend our deepest gratitude to the FDC Foundation. This work would not have been possible without their generous support. Thank you. Let's begin the presentations.
Thank you, Hannah, for that lovely introduction. So my name is Mina, and I'm the clinical research coordinator for this study regarding the use of goal management training and neurofeedback to address symptoms of PTSD. So I'll start off by providing a little bit of an introduction. Then I'll talk a little bit about what GMT is. I'll pass it off to Andrew, who will talk about neurofeedback. Then to James, who'll tell you a little bit about our study design and our results. And then I'll wrap it up with some clinical implications. So post-traumatic stress disorder is a complex mental health condition that can develop in an aftermath of a traumatic event. So things like natural disasters, combat, accidents, violence. And PTSD can really affect anyone who's experienced these events and have profound and long-lasting impacts on emotional and psychological well-being. So unfortunately, PTSD is quite common with a lifetime prevalence of 6.8%. And in fact, in some populations, like public safety personnel, military members who have greater exposure to traumatic events, the rates of PTSD can actually go up to as high as 57%. So unfortunately, PTSD is also associated with high impairment across the board in social, occupational, educational, and physical functioning. It's also associated with reduced quality of life and increased physical health symptoms. So some common symptoms of PTSD are intrusive memories, avoidance, negative changes in thinking and mood, arousal and reactivity, emotion dysregulation, and also problems with cognitive function, which is kind of what we're going to mostly be talking about today.
So as Mina mentioned, post-traumatic stress disorder not only is a very complex and heterogeneous disorder, it's quite prevalent and presents with a high degree of comorbidity. We rarely ever just see post-traumatic stress disorder. It's often co-occurring with things like depression, anxiety, substance use, problems sleeping, chronic pain. And all of this really contributes to how difficult it can be to treat post-traumatic stress disorder. So just to give you a little bit of an idea, we know that dropout rates are quite high from evidence-based psychotherapies. For example, 1 in 3 patients we know will drop out from evidence-based psychotherapies. There's also a large portion of individuals that are treatment resistant to currently available psychotherapies and pharmacological treatments, so treatments with medications. So although we do have some effective treatment interventions available for individuals, we know these are not working for everyone, and there is a high need for novel, personalized medicine approaches to address this treatment gap in post-traumatic stress disorder.
So the brain is a complicated organ, but we can kind of break it down into 3 general areas. The survival brain over there in red, the emotional brain in blue, and the executive brain in green. So the survival brain is responsible for immediate survival responses, and it's activated during perceived threats. It's responsible for asking, am I safe? And in the context of PTSD, people can kind of consistently find themselves stuck in this survival brain mode, which can lead to hypervigilance, heightened arousal, or a very overactive fight or flight response. The emotional brain is the middle layer of the brain, and it's responsible for processing emotions and forming connections with others. In PTSD, individuals might experience intense emotional responses and heightened reactivity to trauma-related triggers. They may struggle with emotion regulation and experience symptoms like anger, anxiety, or stress. And finally, the executive part of the brain. It's the highest level of the brain. It's associated with learning new skills, problem solving, decision making, attention, and more. In individuals with PTSD, this part of the brain can become compromised. Trauma can impact executive functioning when we're stuck in that survival brain. So this is something Andrew's going to touch upon later, but we can try to regulate the survival brain using neurofeedback so participants can effectively engage in cognitive behavior therapy. So when we're talking about GMT today, we'll largely be focusing on that green part, the executive part of the brain. And on some level, this is something we can all relate to because we all know that feeling of being in fight or flight or in survival and feeling like you can't think straight. So another concept that's important to discuss in the context of PTSD is the window of tolerance, which is like our emotional bandwidth or the zone in which we can effectively respond to stress. So what happens with PTSD is this window narrows and people are more prone to going above or below it. So when they go above it, they might experience emotional overwhelm, impulsivity, hypervigilance. On the other end, when individuals go under that window of tolerance, they may experience emotional numbing, withdrawal, feeling zoned out, not having energy, and feeling shut down. So going outside of your window of tolerance can make it difficult to engage that executive brain we talked about. Which is why individuals with PTSD often struggle with executive functioning, especially under stress. When we are inside of our window of tolerance, though, it's associated with calmer body states, feeling more connected, flexible, adaptable with our thinking, and able to access those higher brain areas involved in cognition, decision-making, concentration. So that's why the neurofeedback is a really critical component of this study because it helps individuals expand that window of tolerance and effectively engage in other treatments. We talked about some of the cognitive symptoms of PTSD, and I just want to highlight that these, compared to the other symptoms of PTSD, these are relatively understudied, not talked about as much, and there's not as much treatment available for them, which is why GMT is so critical in this population. Especially because these symptoms actually have very negative impacts on an individual's life. They're associated with high impairment in social, occupational, educational, and physical functioning and a reduced quality of life. So now I'm going to paint a little bit more of a picture of what exactly goal management training is. So it's a 9-week group treatment program, and it can be administered in person, but we administered it online to increase accessibility. And it's designed to improve participants' cognitive skills like memory, attention, and learning challenges. And this is done by helping people to better identify their goals when completing tasks that rely on memory and attention. So for example, creating a shopping list, remembering to pay bills, or completing responsibilities at work. So GMT has already been shown to be helpful in improving memory in older adults, people with ADHD, and people with brain injuries. So we're really excited to show you promising results regarding the fact that it's very helpful in people with PTSD as well. So GMT includes lessons, interactive activities, discussions, and practicing of new skills at home. And mindfulness activities are also part of GMT, which help improve focus and emotion regulation. So in each of the 9 sessions of GMT, a new topic is introduced, which builds upon the previous materials. And here on the right, you can kind of see the titles of the 9 sessions. So just to give you an example of what some of the sessions are like. So in session 3, we learn about automatic pilot by doing an interactive clapping task. We learned that many of the tasks that we do normally, we do on automatic pilot, like driving a car or tying a shoelace. However, automatic pilot can lead us to also make mistakes if we're not monitoring our actions. We learn strategies for present-mindedness to avoid doing this. And we learn to notice when we are in autopilot and bring mindful attention to our actions to avoid those slips. So while GMT wasn't originally designed for this population, there are different ways in which PTSD symptoms actually directly tie into the skills and tasks completed in GMT. So one example is traumatic triggers and how many PTSD symptoms are actually likely to bring you into a state of autopilot. For example, hypervigilance or heightened states of emotion are likely to take you out of the present mind. So a lot of GMT practices give you the ability to observe when you're most likely to go into those states, and then also give you the skills to stop the process. So things like mindfulness or stop, which is learned in session 9. Those things keep you focused before you get into a state of autopilot. In session 5, we draw the analogy of how our working memory is like a mental blackboard that can be erased or even oversaturated with information sometimes. So we learn to go back and check the mental blackboard to keep our current goals at the forefront of our mind. So again, relating this to PTSD, the mental blackboard can become wiped by traumatic reminders, which can impede your working memory. So practicing with visualization and other skills with GMT teaches us to keep our mental blackboard with our current goal in mind. And GMT is great in that it builds on those skills and they become more and more advanced with each next session. And you also practice integrating and using those skills in your daily life. In session 8, we practice completing tasks that are too complex to rely on working memory and use strategies to divide larger goals into a series of smaller, more manageable ones. So these are just a few examples of how GMT builds skills and awareness to improve cognitive function. And ultimately, the goal of GMT is to empower individuals to regain or enhance their ability to set and achieve meaningful goals, improve their quality of life, have a sense of independence, and improve their overall well-being. So a lot of really interesting work is coming out of our group demonstrating the use of GMT in veterans, public safety personnel, inpatients, and what we were really looking to do here is to extend this research to civilians utilizing an online virtual delivery of the GMT groups. This, of course, improves accessibility for people living in more remote or rural areas. And this was also launched during the COVID-19 pandemic, so we were interested in the effectiveness of this delivery. And then finally, we also combined goal management training with neurofeedback as an adjunctive treatment. And what we are really looking to do with that is to widen that window of tolerance so that people can more effectively engage in GMT. And now I'm going to pass it over to Andrew to tell you a little bit more about neurofeedback, some of the research on it, how it works, and how it relates to the study.
Thanks, Mina. So now we've heard, this term neurofeedback now a couple of times during this presentation. So I would just like to spend a little bit of time just explaining, what that is and how we can use this as a tool, as Mina said, to widen that window of tolerance to both regulate on a neurobiological level PTSD correlates in the brain, but also widen that window of tolerance so that people can more effectively engage in other forms of psychotherapy and trauma processing. So neurofeedback is a non-invasive form of biofeedback. Biofeedback has been around for decades, and this just involves processing some biological signal in real time, and then we feed that signal back either as a visual display or as an auditory signal, and people try to gain control over that signal as a way to self-regulate. So for example, we have heart rate biofeedback where people try to regulate their heart rate, but neurofeedback involves processing brain activity in real time. And what this means in the context of PTSD is that patients can learn to non-invasively self-regulate brain activity that's directly tied to their PTSD symptoms. And this is very interesting and important because it allows people to search for individualized strategies that work best for them to control specific symptom presentations. And essentially, as Mina mentioned, there are specific brain networks that can become dysregulated in the aftermath of trauma, and these are resulting in symptoms of PTSD. And what we try to do with neurofeedback is try to recalibrate and re-regulate some of those brain networks to reduce symptoms of post-traumatic stress disorder. And one way we can do this is with something called electroencephalography neurofeedback, or EEG. And this involves processing and measuring brain waves in real time. And there are many different brain waves that we could measure with EEG neurofeedback, but today I would like to focus on alpha waves. And these really reflect a state of relaxation and rest. And as you can imagine in PTSD, alpha waves are significantly decreased. So we don't have that relaxed, calm state in a resting state. We see more hypervigilance, hyperarousal, and on the neurobiological level, activation in brain areas that are really concerned with survival, fight or flight, and defensive posturing. In a recent randomized control trial that we conducted by our group, we looked at the efficacy of 20 weekly sessions of EEG neurofeedback targeting those alpha waves. So again, those brain waves that reflect a calm, relaxed state. And this is what the protocol looked like, where the spaceship, participants were told this spaceship would only move across the screen when they were in this target zone of alpha waves. So when they were regulating those brain waves corresponding to a calm, relaxed state. And again, we did this over 20 weekly sessions. And what we actually found in this study was that the active treatment group, who was receiving real neurofeedback, as compared to a sham control group that was receiving fake neurofeedback signals, we actually saw only significant decreases in PTSD severity scores before and after treatment in the active intervention group, and this was sustained at a 3-month follow-up. What's very interesting and promising, and I think provides a lot of hope for people in this study, was that over 60% of individuals no longer met diagnostic criteria for PTSD after the trial. So there was a 61.1% remission rate, and there were no patient dropouts as well, which I think really speaks to the tolerability of this type of intervention. Additionally, on the neurobiological level, we actually saw that those brain waves, those alpha brain waves that reflect a state of calmness and relaxation that typically are decreased in PTSD, these brain waves were restored after treatment, so they were recalibrated. So essentially, this figure is showing in blue areas of the brain that had decreased calm brain waves at baseline among those with post-traumatic stress disorder, and these were actually restored after intervention in the active treatment group only, as shown in yellow. So we were able to rebalance and resynchronize those alpha brainwaves with neurofeedback training. Interestingly, other neurofeedback clinician researchers in the field, such as Bessel van der Kolk and Sieber and Fisher, have hypothesized actually that this type of intervention, neurofeedback, may be particularly beneficial for those who might be too anxious, dysregulated, or dissociative to tolerate other first-line treatment interventions for PTSD, such as prolonged exposure or cognitive behavioral therapy or cognitive processing therapy. And what we really tried to do in the current study is investigate whether or not we could utilize neurofeedback as an adjunctive treatment to goal management training to help widen the window of tolerance for individuals before going in to engage in that group therapy. We also wanted to investigate if neurofeedback could be used as a tool to help regulate and facilitate optimal emotion regulation on the neurobiological level, again, to help improve treatment gains for goal management training. And as Mina mentioned, we launched this study at, right in the middle of the COVID-19 pandemic. And one of the goals of this research study was to look at the feasibility, tolerability, and efficacy of a virtual online format of goal management training. So how we accomplished the neurofeedback component of this is we utilize an accessible and portable form of neurofeedback with the Muse headset. So again, we shipped this to people's houses, and this allowed us to do in-home virtual delivery of neurofeedback. And just a quick introduction to what the Muse headband is. This is a wireless electroencephalography, so EEG system, that interacts with a mobile device. So you can either have this connected to your phone or a tablet, and it's measuring essentially active and calm brain states to provide real-time performance feedback. And again, we utilize this in a adjunctive way to the goal management training to see if we could optimize that window of tolerance and improve the treatment gains of goal management therapy by regulating the emotion centers of the brain on a neurobiological level. So now I'll pass it over to James, who will talk to you a little bit about the study design and share with you some of the exciting results of this project.
Thank you very much, Mina and Andrew, for introducing the concept of GMT and neurofeedback. My name is James Marabelli. I'm a PhD student and statistical analyst at the McMaster Trauma and Recovery Lab, and I'm going to go through some of the methods and results of our study. So, for a randomized control trial of GMT and neurofeedback, we recruited 77 individuals with PTSD who reported cognitive impairment. We excluded military and public safety personnel, such as firefighters and police officers and paramedics, as well as individuals with traumatic brain injuries and individuals diagnosed with mental illnesses associated with psychosis. All participants were assessed at baseline prior to treatment and randomized to one of three groups: those who received 9 weeks of GMT only, those who received the same GMT treatment for 9 weeks as the GMT group, but also conducted a 30-minute neurofeedback session with the Muse headband prior to each GMT session, and a waitlist control group who received no treatment for 9 weeks. Our primary outcome measure was clinician-assessed PTSD symptom severity, with secondary outcomes including neuropsychological tests and questionnaires assessing cognitive and psychological functioning. Participants were assessed immediately following 9 weeks of treatment or 9 weeks post-baseline for the waitlist, as well as at 3 months post-treatment. Now, to some, this procedure might sound simple, but I want to give a shout out to everyone who came together to make this happen. A large amount of work went into this project, and it might go without saying, but recruiting and screening enough participants from this specific population, coordinating group therapy sessions, and multiple 2-hour assessment times over 3 time points with this many participants, all of them whom report cognitive impairment, and managing 9 weeks of treatment with a large number of people regardless of cognitive impairment, as well as controlling for logistics for Muse headband delivery, as well as individual Muse training sessions for each participant, all of it. Everyone came together to make it happen, and we couldn't be happier with the results. So, as I was saying before, our primary outcome measure was PTSD symptom severity, which was measured pre, post, and follow-up using the gold standard clinical interview for PTSD, the CAPS-5. We found that for GMT-only group, their PTSD symptoms decreased significantly by the end of treatment. And when we followed up with them 3 months later, we found that this decrease in PTSD symptoms was maintained over time, but did not continue to improve in this window. But on the other hand, with the GMT plus neurofeedback group, we found that they significantly decreased in their PTSD symptoms by the end of treatment, and when we followed up with them, their symptoms had continued to decrease over time. And this is compared with the waitlist, whose PTSD symptoms did not change over the period of the study. One of our secondary outcomes was a measure of processing speed. This is the digit symbol substitution task. The participant was given a key with numbers that match symbols at the top here, and then a grid only having symbols. So they were to fill in as many of the blank spaces with the numbers that would match those symbols as possible within 2 minutes. And we found that processing speed did not improve in either the GMT only group or in the waitlist condition, but this did improve in the GMT plus neurofeedback group, and this improvement was maintained at the 3-month follow-up period. And finally, we administered a questionnaire battery to each participant, which included measures of dissociation, emotion dysregulation, depression, anxiety, stress, and self-perceived cognitive failures. Now, this is a simplified description, but dissociation describes, particularly for people with PTSD, feelings like their surroundings are unreal and almost dreamlike, or disconnection from their body, commonly described as an out-of-body experience. And dissociative experiences were measured using the multi-scale dissociation inventory, or the MDI. And we found that for both the GMT only and the GMT plus neurofeedback group, dissociative experiences decreased significantly over treatment, and these decreases were maintained after the 3-month follow-up period. And again, there was no change in dissociation in the waitlist condition. We also measured emotion dysregulation, or difficulties with controlling negative emotional states or behaviors associated with these emotions, using the Difficulties with Emotion Regulation Scale, or the DIRS. And we didn't note any changes in emotion dysregulation in the GMT only group or in the waitlist condition. However, similar to what we saw with PTSD symptoms, there was a decrease in emotion dysregulation in the GMT plus neurofeedback group following treatment, and emotion dysregulation continued to decrease over the 3-month follow-up period. Depression, anxiety, and stress were all measured using the Depression, Anxiety, and Stress Scale, or the DAS. And we saw something interesting with depression. So for the GMT only group, their depressive symptoms did decrease over treatment, but this decrease was not maintained over the 3-month follow-up period. There was almost a rebound effect, and it wasn't so large of a rebound effect that it was caught as an increase in depression during the 3-month follow-up, but it was enough so that there wasn't a statistically significant difference in depression from baseline to the follow-up period. Now, in contrast, we did see a significant decrease in depression over treatment that were maintained over the 3-month follow-up period in the GMT plus neurofeedback group. And again, there was no change in the waitlist condition by contrast. We also saw the same effect that we saw with depression with anxiety symptoms, where there was a decrease in anxiety in both the GMT only and the GMT plus neurofeedback groups that was not maintained over the follow-up period in the GMT only group, but was maintained in the GMT plus neurofeedback. However, when it came to stress, both the GMT only and the GMT plus neurofeedback groups had decreases in stress over treatment, and this decrease was maintained over the 3-month follow-up period. Finally, we measured perceived cognitive failures, which describes how often the participant experiences mental slip-ups such as forgetfulness, misplacing objects, losing their sense of direction, or lapses in attention. And this was measured using the Cognitive Failures Questionnaire, or the CFQ. And once again, we saw the same pattern that we saw with depression and anxiety, where cognitive failures decreased over treatment in both the GMT only and the GMT plus neurofeedback groups, but were not maintained over the 3-month follow-up period in the GMT only group, and were maintained in the GMT plus neurofeedback group. And again, we saw no changes in cognitive failures in the waitlist condition. So just to summarize what we found in our trial of GMT and neurofeedback, PTSD symptoms decreased in both the GMT only and GMT plus neurofeedback groups, and this continued to improve post-treatment for only the GMT plus neurofeedback group. Processing speed only improved in the GMT plus neurofeedback group. Dissociative experiences improved for both groups. Emotion dysregulation improved only in the neurofeedback condition and continued to improve post-treatment, much like the PTSD symptoms. Depression and anxiety decreased in both the GMT only and the GMT plus neurofeedback groups, but this improvement was only maintained in the GMT plus neurofeedback group. Stress improved in both the GMT only and GMT plus neurofeedback groups. And cognitive failures showed the same pattern as depression and anxiety, where improvements were only maintained in the GMT plus neurofeedback group. So basically what we're seeing here is that GMT works well for improving PTSD symptoms, dissociation, and psychological health. However, we're also seeing evidence that neurofeedback may improve upon GMT and may help maintain gains experienced through GMT. Thank you very much. I'm going to hand it over to Mina to discuss some of the implications of this study.
So we did also ask the participants about their feedback. We wanted to hear about what this experience was like from them, and we got overwhelmingly positive feedback. So regarding the GMT groups themselves, we asked participants to kind of rate it from 0%, not helpful, to 100%, very helpful. And the average response was actually 78%. Whereas for the neurofeedback mindfulness training, they indicated that it was 87. So they liked that piece even more. And now I just kind of want to touch upon some of the clinical significance. Like, why does this study actually matter? So cognitive symptoms of PTSD significantly impact a person's daily life, and there's not a lot of treatments available. So that's why it's such promising results that GMT can actually address these symptoms and lead to a notable improvement in individuals' quality of life. Also, cognitive symptoms can make it difficult for individuals with PTSD to engage effectively in other types of therapy as well. So by improving these cognitive abilities, GMT makes it more likely that individuals will adhere to treatment plans, actively participate in the therapeutic process, and also regain a sense of self-efficacy. In terms of the clinical significance of neurofeedback, many individuals with PTSD find it challenging to engage in exposure-based therapies or cognitive behavioral interventions due to that heightened emotion dysregulation, that anxiety, that narrow window of tolerance like we've been discussing, that overactive survival brain. So this study really demonstrates that neurofeedback can be a valuable adjunctive therapy to expand that window of tolerance, as it targets the brain's regulatory mechanisms. In fact, neurofeedback has the potential to improve emotion regulation, reduce physiological arousal, and make individuals more receptive to trauma-focused treatments. So we can see that neurofeedback can work in conjunction with other evidence-based therapies as well, and prepare individuals to kind of engage in those therapies by achieving a more stable and regulated emotional state. In addition to an adjunctive therapy, we can also think of scaffolding neurofeedback. So having neurofeedback integrated at the beginning of a treatment plan to create a stronger emotional foundation for subsequent interventions. The great thing is that, a lot of these clinical implications, clinical significance, are also things that we saw in our feedback from participants. So one participant said, I found it to be productive and it helped me to be accountable for my progress. So kind of going back to what we're talking about adhering to treatment plans and actively participating in the therapeutic process. In terms of feedback we got regarding neurofeedback, individuals and what we were saying about kind of neurofeedback preparing individuals for other trauma treatments by helping them achieve a more stable and regulated emotional state and increase individuals' ability to engage in treatment without being overwhelmed. We also saw that in our feedback. So one participant said that it helped them control their emotions on a deeper level. Another participant described it as an oasis of calm. Another participant said that it was very difficult at first, but over time it became easier. So a lot of these clinical implications that we hypothesized would come about are also directly seen in the participants' experiences. So I just want to thank you all for making the time to join today, for listening, and I really hope that this has been a valuable session and has allowed you to learn a little bit about how goal management training and neurofeedback can be useful in this population. Thank you.
Wow, well, I really want to thank Mina, James, and Andrew for their presentations. And of course, they are here to take your questions. If you, like me, are just experiencing or learning about GMT and neurofeedback for the first time, I'm sure you're filled with questions. So now is your opportunity. You can click the Q&A button at the bottom of your screen. And I would like to also welcome Dr. Margaret McKinnon right now. She is the Homewood Chair in Mental Health and Trauma and Professor and Associate Chair of Research in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. And of course, we are welcoming back Andrew, Mina, and James. Thank you so much. Also joining off camera to help us bring all of your questions, audience questions from the Q&A is Hillary Dort, who is HRI's Manager of Communications. She is off camera, but you will be hearing her voice reading out your questions. So thank you all for joining us today. Hillary, can you share the first question from the audience?
Hey everyone, absolutely. So our first question from the audience today is, how does the approach address traumatic memories?
I see Margaret nodding. Maybe that's a question for you.
Thank you so much for that question. So this is, I would describe it as a present-based therapy. So rather than reflecting on the past and past events, it's never focused on building skills that will help us in the present moment. So for example, building increasing our window of tolerance, dampening down impulsivity, working on skills that will really help us in the moment as opposed to reflecting on past experiences. And there was a recent meta-analysis looking at treatment for PTSD, and it revealed that present-focused therapies that focus on the building of skills in the present moment can be just as effective for treatment as past-centered therapies that focus on past experiences, so in particular traumatic memories. But thank you for the question. I think it's a really important one, and it really highlights that there are multiple pathways towards treatment for PTSD. We often focus in our research group on present moment therapies or present-centered therapies, but certainly past-centered therapies are part of the toolbox for treatment of PTSD as well. But thank you for that question.
I do want to get through as many questions as possible, so maybe we'll let one person answer per question, but if there's anybody on the panel who wants to jump in, please do. Just raise your hand or jump right in. Shall we move to the next one, Hillary?
Absolutely. So the next question is, what is the best way to rebuild organizational skills after substantial trauma?
Who would like to take that one? Andrew?
Oh, I think Margaret had her.
Oh, I'm sorry. Okay, please go for it.
No, thank you for the question. So part of the reason that we began this work surrounding goal management training and neurofeedback is that, we had worked in clinical practice, seeing individuals who had experienced post-traumatic stress injuries, and recognized that I'm a clinical psychologist and a clinical neuropsychologist, and often we would, perform a comprehensive clinical assessment. And it would reveal that people had difficulties with executive functioning, attention, memory, but we really didn't have a form of treatment for those difficulties. We would describe the pattern of cognitive difficulties, but at the time we might give advice like, take breaks, space out the time in which you're working on a task, repeat, so repetition of learning, but we didn't have a treatment approach. And so at HRI, about close to 10 years ago now, we began trialing goal management training is the first form of treatment for cognitive difficulties in post-traumatic stress disorder. And what we found is that this treatment tends to, number one, teach people how to stop and be in the present moment. Before they engage in a task, it teaches them to stop and think before they do that. So rather than, for example, when you're in a discussion with someone and you're having a difficult discussion, and we might often want to blurt something out, it reminds us to stop and think about the consequences of blurting that information out. Or if we're engaged in a complex planning task where, for example, we need to go to the grocery store, pick up multiple groceries, think about a recipe that's in our head, we learn to stop and break that down into small steps and then continuously monitor our performance on those small steps. So I think that Charlene O'Connor is here. She's a really exceptional GMT clinician who helped to develop this treatment program. And she would always say that, learning to stop and to be in the present moment is very important, which is what GMT teaches. And also to break complex tasks down into small steps and then monitor our progress on those small steps. So that's very broad description, but I think those are some of the key elements in goal management training, which in our multiple studies with military members, veterans, public safety personnel, and now civilians, we really do see the impact of GMT on those cognitive functions.
Our next question, Hillary.
Wonderful. Okay, so the next question is there a way to do neurofeedback without access to specialized equipment?
Great question. Who would like to take that one?
Yeah, I think that's what we were really trying to explore with this study, right? So in our previous clinical trial, this was done in the lab using quite sophisticated equipment. We also do neurofeedback with fMRI, which is quite sophisticated and very expensive, but also not super accessible. And that was kind of the next step of this research program, was to use a consumer grade technology such as the Muse and actually deliver this in a virtual environment and do training on how to use this device virtually. And so I think our results are showing that this is quite promising. There are also studies, a recent study that's come out from a group in Rwanda that's used another form of neurofeedback similar to the Muse as a cost-effective and portable way to administer neurofeedback. So I think it's really important to show these proof of concept studies, you know, with fMRI and very sophisticated EEG equipment, but then also making sure this is clinically translatable.
Thank you, Andrew.
I could just add, I think we really have a focus in our group on thinking about how do we deliver treatment to individuals who don't have access to, you know, high acuity centers, don't have access necessarily to inpatient treatment, or seeing a psychiatrist or a psychologist. How do we deliver treatment out in the community to people who live in rural regions, remote regions? We want to be cost effective and really increase the reach of treatment. And I think in part by administering the therapy online through the internet-based intervention, we can also reach more individuals. And we were really, really pleased that we could reach out to people, for example, in Northern Ontario and other regions who typically wouldn't have access to these cutting-edge clinical trials.
Thank you. Hillary?
Wonderful. So we've had a couple of questions come in around medications. So the first one was, were people who are taking medication for anxiety or depression included in the study? And then follow up to that would be, can medications affect neurofeedback results?
James, you were talking in your presentation about who was included in the study. Would you like to take this one?
Absolutely, no problem. So we did include people with anxiety medications. We were specifically looking for people without psychotic illnesses because of the type of medication that they would take may affect the results of the study. There has been some evidence of some medications affecting the effects of GMT. I'm not really 100% sure about neurofeedback. Andrew, I think you probably know a little better about that one.
Yeah, so there has been some research showing that certain medications like SSRIs or selective serotonin reuptake inhibitors can affect neuroplasticity between some of the emotion regulation areas of the brain and limbic areas that are really generating the emotions. In this study, we recorded medication use throughout the duration of the project to include as covariates in the analysis, but we weren't powered to look at the specific effects of those medications. We did want to have a naturalistic, though, and generalizable type of sample for this project.
Margaret, go ahead.
Yeah, I just want to be very cautious to say, well, we have, as Andrew was saying, we have carefully coded participants in terms of what sort of medication they have. In none of our studies have we been able to examine specifically the impact of medications on GMT. And just as Andrew was saying, we conducted an an effectiveness trial. So there are two types of clinical trials. One is an efficacy trial under really tightly controlled conditions that often don't mimic the real world. So this is what we often see, for example, in medication trials for PTSD and depression, where people have only one form of a mental health condition. They maybe have medication washout where they're not on medications during the trial. We wanted to conduct an effectiveness trial, which means how would these treatments operate in the real world? So when people come into treatment, often on many medications, when they have comorbid conditions or co-occurring conditions, so PTSD often co-occurs with depression, for example. We want to see how this operates in the real world, and that's actually a much more stringent test of a treatment because we're not trying to tightly control every variable. We're saying, when you're working in a mental health clinic or at a hospital, these are the sort of patients that you're seeing, and we want to help those patients, not just those who exist under very tightly controlled conditions.
I could just follow up to Margaret's comment. Margaret, there's several attendees today that have joined because they're really interested in the cognitive symptoms of PTSD. And I know they had approached me before the webinar because they had read about a couple of studies that have actually excluded people that have demonstrated cognitive or executive dysfunction from the project. And I wonder, this kind of relates to your previous response, but I wonder if you could speak a bit more to that of people being actually excluded because of these symptoms from other trials with PTSD.
Yeah, no, thanks, Andrew. I think that's a really important question. And thank you to those of you who have joined us with this question. I again think that we really want to be thinking about real world conditions with treatment interventions. Cognitive difficulties, so difficulties with memory, planning, executive functioning, processing speed, are very much a part of PTSD. PTSD is often considered a fear-based condition where people are struggling with a fear, for example, of returning to circumstances that remind them of the trauma. But in fact, our understanding of PTSD has really expanded. We understand, for example, that people struggle with shame and with guilt. There's a particular subtype of PTSD called the dissociative subtype of PTSD, which Mina was alluding to, where people, rather than being hyper-aroused, so easily startled, irritable, high levels of arousal, these patients show low levels of arousal, where often they're numbed out, don't feel present in the world around them, have difficulty connecting with others. So when we talk about PTSD, we're really talking about a host of symptoms that go far beyond fear-based conditions. There is a belief that some antidepressant medications impact upon cognitive functioning, but it's often not an outcome in medication trials of PTSD. And I would argue very strongly that we should be looking at those cognitive outcomes as well. So looking at executive functioning, processing speed, memory, and attention. I'm not going to comment specifically on others' work who exclude patients with cognitive difficulties because I wasn't involved in those trials. I want to be very careful not to make a comment that, maybe I don't have a full amount of information to make any sort of opinion regarding that. But I would say I think cognition is a very big part of post-traumatic stress injuries, that we really need to be examining cognitive functioning is part of trials, treatment trials. Medication trials are non-medication trials for PTSD. There's a study conducted in Canada many years ago with patients with depression, and they were asked, after they've received treatment and their depressive symptoms had lessened, what continues to bother you? What sort of difficulties do you still experience as a result of this mental health condition? And many said, I still struggle with cognitive difficulties. I'm still struggling with my planning, my memory, my processing speed. And I feel that, this has continued even after my depressive symptoms have lifted. We want to be thinking the same way around post-traumatic stress injuries, where cognitive difficulties are persistent in many cases, and we want to continue to target them with treatment, both during recovery, but even after recovery for some individuals. That's a long-winded answer. I apologize, but that is yeah.
Thank you,
Not
Margaret.
long-winded, fascinating, and all the questions about medication in the Q&A had led to this and the inclusion, exclusion, cognitive difficulty. So thank you for all the questions. We do have time for a couple more. Hillary, do you have one lined up?
Absolutely. So another theme that's emerging is how neurofeedback can be used as an adjunctive therapy, along with things like other types of psychotherapy, or someone here is asking in the Q&A about occupational and physical therapy practice. Are there other ways that we can use neurofeedback?
Yeah, I think one of the, benefits of neurofeedback is that it is, so flexible. And that's what we try to explore in this study is looking at neurofeedback as an adjunctive treatment to GMT. In other studies that we've conducted, we've done solely neurofeedback on its own. We've also paired it with a prolonged exposure type of paradigm as well, where people are viewing personalized trauma words and stimuli and trying to regulate some of those emotion centers and the survival regions of their brain. But we're excited to embark on more research avenues to see how else we compare neurofeedback with other types of adjunctive or emerging therapies. One that we're really keen on exploring is pairing neurofeedback with more sensory motor, kind of bottom-up type of therapies. So I know Margaret McKinnon is launching a new study as well on these types of interventions. So there's many different avenues we could explore. I don't know if Margaret, you want to mention anything else about those.
I'd love to mention our new studies. So we're very fortunate to have funding from Veterans Affairs Canada to develop a new treatment approach that does target those bottom-up aspects of post-traumatic stress disorder. So we often assume that post-traumatic stress injuries can be treated through top-down, changing our thoughts, and our thoughts will change our emotions. So that's more of a cognitive behavioral approach to treatment of post-traumatic stress injuries. And that certainly has demonstrated efficacy or effectiveness in many different studies, but we often forget that emotions drive thoughts. And what's often driving the emotion is a bodily sensation. So we can think, for example, about that sensation where you feel like you have a kick in your gut or something feels wrong to you. And that bodily sensation will often drive emotions in the brain. So, Ruth Lanius and others, Andrew, their work shows, for example, the periaqueductal gray, which is a region of the brain responsible for processing of raw emotion. It shows altered functioning in post-traumatic stress injuries. We can also think about the amygdala for processing emotion and other limbic regions. These brain regions are seldom on the target of treatment. So we often focus again on that top-down, cognitive, thought-based treatment, but we need to be looking at how we regulate bodily sensations and also bottom-up lower levels of the brain, because those emotions and bodily sensations will drive thoughts, right? And so we have developed a new treatment called SENSE. It's been in collaboration with many people in our lab, including Alison Mizzi, Shireen Harris-Sharon, Christina Chrysler, and others who are here today, to really focus on those bodily sensations and the regulation of lower level brain regions, which we think by altering bodily sensations and the emotions that follow will help people to be, again, more centered, more present in the moment, and better situated to benefit from forms of therapy that, for example, assist in processing of traumatic memories, as an example. So this is done in children who are behaviorally dysregulated to help them to bodily regulate before higher level, more cognitively oriented therapies. And so that is funded by Veterans Affairs Canada for military members, veterans, and we're also recruiting public safety personnel. We'd like to also be doing this in civilians, and we'll be looking for forms of funding for that as well. Thank you.
Look forward to hearing the results of that study. That's fascinating work that you're working on right now. And I'd like to say that we're almost out of time. We do have time for one more question if we didn't get to your questions today, because there are many. And if you'd like to connect with HRI, please visit hriresearch.com for Homewood's contact details. Also, just before we get to our last question, I want to take a minute to let you know where you can find information and resources for GMT facilitator training. You can visit Baycrest GMT Learn World. We've posted a link in the chat, and we will include it with our follow-up emails after the event as well. We have also posted a link to a brief survey in the chat where you can offer feedback on today's session. You'll also find the survey launched on Zoom immediately following the event. So thank you in advance for filling that out. And with that, I'll go to Hillary for our last question.
Thank you, Hannah. So another theme that has emerged is around access. So people are asking how this treatment can be accessed or if it's available. And the flip side of that has been people who work in mental health treatment asking about access to GMT training and whether or not you need specific credentials to use neurofeedback. So if someone could speak to that, that would be great. Thank you.
Maybe I could briefly talk about the neurofeedback part and then pass over to Margaret for the GMT training. So I see that it was posted in the chat, a web page that we created at the Atlas Institute for Veterans and Families surrounding neurofeedback. It has a frequently asked questions section and some infographics and resources you can download. One section on that website is surrounding access. So for, some insurance companies are covering neurofeedback treatment. And for that to be covered, the clinician is meant to be biofeedback certified. So through the BCIA, which stands for Biofeedback Certification International Alliance. And interestingly, on that webpage, I think it has some great prompts of things to consider when you're thinking about neurofeedback, particularly for PTSD. So things like, what is the educational background of the clinician? Are they going to be administering kind of trauma-informed neurofeedback? Is it going to be paired with another frontline treatment for PTSD, et cetera? So I would definitely encourage those of you who are interested to check out that web link, and I'll pass it over to Margaret for the GMT component.
Yeah, and I must say that one thing that's really important is to acknowledge those individuals involved in the development of these treatment approaches. I should have also mentioned Dr. Hugo Schlecki, who's been involved in the development of the SENSE protocol. And so Uga is a psychologist at Homewood Health Center, and I just wanted to mention them as well and their treatment, how their involvement in the project. With respect to GMT, it was developed at Baycrest Center in Toronto, along with at Trinity College Dublin, and the main developers are Brian Levine and Ian Robertson, and Charlene O'Connor was also very much involved in that. Baycrest does offer training for GMT, and those resources are available in the chat below. We have offered GMT at the Operational Stress Injury Clinic in Quebec City with Dr. Edouard Auger and Vicki Lavoie. We are hoping to be offering it at other operational stress injury clinics across Canada. There's been some tremendous interest in that. I'm always happy to connect and talk about that. Homewood Health has offered GMT through its return to work program, so that's another potential offering. But I would say that GMT, much like neurofeedback, can be administered by a host of different clinicians. So one may be an occupational therapist, a nurse, a psychologist. Really what you require is a knowledge of brain functioning in order to become involved in this therapeutic intervention. And that training is offered through Baycrest Center. And we have those resources there for you if you'd like to access that. I do think we'd like to see more adoption of GMT across different treatment sites in Canada. So for example, through outpatient neuropsychology clinics and hospitals, private practice psychologists or other healthcare providers may want to offer it. And so I would really encourage people to look at the literature. We have a number of publications, randomized control trials looking at the use of GMT in depression, anxiety, and PTSD, and those are available if you Google McKinnon and goal management training. You will find those publications. So I really encourage you to take a look at those and consider using this across a host of different neuropsychiatric conditions, because I think it does have effectiveness rather for these conditions. Thank you.
Thank you. Because we've reached the end of our time for today's presentation, I really want to thank all the panel members, Dr. Margaret McKinnon, Dr. Andrew Nicholson, Mina Pichtakova, and James Mirabelli. Thank you. And to all of you watching today, thank you for being here and for prioritizing your interest In learning about GMT, neurofeedback, and its use in treating PTSD, we will be posting a recording of this webinar on YouTube within the week, and we invite you to share it with the people in your lives. Also, we've posted the brief survey. It'll be in your inbox, as I mentioned, so please take a minute to offer some feedback. One more big thank you to our funder, the FDC Foundation. We are so grateful for your investment in this important work. Thank you to everyone for being here. Have a great day.